Okay, so good morning. My name is Helen Kim. I'm a nurse practitioner from the Friedrich Otolaryngology Clinic. I've given the health assessment course discussion before for the physical exam portion and history taking, but now this is a whole new lecture that I've designed for this particular class on managing ENT disorders. And so what I've done through this lecture is to try to come up with the most common conditions that you would most likely find in a primary care setting. And based on various resources and references with guidelines, I have tried to come up with an algorithm as well as suggestions on how to manage some of these patients. So I will be asking all of the students who will be watching this in the middle of today's lecture, as well as those who will be looking at the actual PowerPoint on the recording, if you can please provide some pertinent input, actually, for evaluating this class, because I would like to really try to make it better and designed better for all of you in the future for future sessions. So whatever input that you have for me, you will be my guinea pigs, and I need all of your feedback and try to be as helpful as possible for me so I can make it better for future classmates. So I greatly appreciate that. All right, so we're going to start with an outline. We're going to be covering most common ear, nose, and throat conditions, and this gives you a quick overview of what some of those topics will be, plus or minus a few additional things. All right, so basic method, obviously a didactic lecture, which is pretty much with all of our lectures. You'll be using some evidence-based guidelines, which I will be pinpointing throughout the lecture. There will be a few basic case studies that I will be discussing throughout the entire lecture, and flowcharts and graphs with a few illustrations. Now, this lecture is not as heavy on photographs and images as I had with the health assessment. It's very content heavy, so there's a lot of writing in between. Okay. Now, guidelines and evidence-based statements, something that we all are increasingly becoming more aware of, is this really fuels the way that we manage our patients. So in this statement, I wanted to review this. Guidelines are intended to reduce inappropriate variations in clinical care to produce optimal health outcomes for the patients and minimize harm. Guidelines are generally never intended to supersede our actual professional judgment, whether they are viewed as relative constraints or to be used based on individual clinical discretion in how you actually handle a patient's case. Clinicians should always act and decide in a way that they believe is best served for the patient and never strictly go by guidelines when it's not appropriate for that individual patient. So you must use your judgment, and with that comes experience as well. Okay, we're going to start out with common ear conditions. So here we go. Sewer impaction, a very common problem that everyone has to deal with, and you'll see this many, many times, as well as we do in ENT. Typical presenting symptoms include ear fullness, some ear pain, hearing loss, tinnitus, some symptoms of vestibular problems such as dizziness, and oftentimes itching as well. Typically, some patients may experience some bleeding as a result, because if they have been impacted for so long, they may become infected and have some drainage and bleeding with severe pain involved. There are other cases where they could be developing problems with perforation, so you have to be careful to figure out if there's any history of ear surgeries, perforations, ear trauma, if whether or not there's any history of some form of congenital disorders that may impact the overall anatomy of the ear canal as well as middle ear. So these are pertinent histories that you should be asking before you do anything with the ear. Find out if they've ever had any ear surgery, and if whether or not they have an ear tube. You certainly don't want to be flushing ear in somebody who's had a history of ear surgery or a tube or perforation in the ear. If they often have a history of frequent ear infections, you want to be more cautious. Some patients with dermatological conditions in the canal, those also you don't want to be using any form of water flushing. Find out from them if they typically do things on their own by using Q-tips or other things like water irrigation or ear drops from over the counter, and what their typical behaviors are for self-management of cerumen. Now, when you do the actual exam, obviously, as we taught before how to use the otoscope, you want to take a good look around the ear to see if you can see the cerumen or if there's no cerumen and what things look like inside the ear. So different characteristics of types of earwax will be either dry and flaky to wet and moist to dark to light color. There are a few populations that I mentioned earlier that you want to be very particular with, especially with using water irrigations in a lot of clinical practices. These are the certain types of patients I prefer that they not use water, particularly individuals with diabetes, with intractable blood sugars, Somebody who has congenital impairment of hearing, you don't want to risk any trauma to the ear. Anybody who's had a history of surgery of the ear in the past, ideally those patients, you want to have them actually be managed through ENT. Anyone who's had a history of radiation to the head or neck. The radiation does cause changes to the epithelium, which causes excessive accumulation and production of dead skin, making them very frail for risk of infection and trauma. If you try to do anything in the actual clinic setting, in our ENT clinic, we use binocular microscopy and other tools to directly visualize the ear to be a little bit safer so that we can easily manage the ear from our specialty. There are people also, as we've talked before in our health assessment class, that they have bony masses or a contour of the ear that's a little bit abnormal. You also want to be careful to try not to use any instruments to potentially cause any damage to the inner ear and cause bleeding from there. Especially for somebody who also has immune compromised states like HIV, or they are on chemo or have any form of leukemia, they also have increased risk of serious complications and infections from having potentially traumatic ear cleaning. Cognitive functions, some people who have dementia or Alzheimer's or other cognitive delays, if their hearing is impaired by cerumen impaction, their cognitive function can dramatically change and get worse because of their inability to adapt to what's going on around them and being oriented to sounds around them. So cerumen impaction causing hearing loss in these populations is quite a serious problem, actually. So you do want to have that managed. Okay. Oh, one more thing. Patients who do also have hearing aids are also at risk for frequent ear infections because their ear canals are constantly plugged. You do want to make sure that they frequently have their ear cleaned as well. Only problem is if you use water and they wear their hearing aid again all day long, you're trapping the moisture, increasing the risk of infection as well. So you want to be a little bit more careful with them and try not to use any water. Treatment of vulnerable populations additionally requires a specialized skill and expertise in managing these patients and removing earwax. A lot of it's just experience and just kind of becoming a little bit more familiar with different techniques and tools out there. And being able to make the best judgment in how you feel comfortable. And if you don't feel comfortable, then certainly feel free to refer them to someone who is more trained in how to manage that. Just be careful, as we talked about, as an ENT, we do have microscopes and tools and equipment. Yes?
When you say about not using water, so if we do irrigate them in our practice, what type of solution do you recommend using?
Typically just water.
Just water?
Yeah.
Okay.
But again, there are certain patients that you really shouldn't be doing that, which are those patients I was just discussing. You just don't want to use any moisture in the ear. Okay. All right. So there are agents called cerumen-lytics such as Dermotic, which is an over-the-counter product that softens up the cerumen and that is meant to be flushed out at home. Some people do have tools or irrigating equipment that they try to irrigate on their own at home. I generally try not to advocate doing that on patients unless we have confirmed that they have a normal, healthy ear, and they don't have any risks of potential infection or risk of trauma. All right. Other things include a lot of abuse of Q-tips. We, again, discourage patients from using that at home or other types of tools. I have seen plastic ear probes that people have found that they can start digging around, but again, I generally prefer that patients not do that. And education and counseling is very pertinent. People who often use earplugs, headphones, again, they're plugging the ear throughout the entire day, minimizing any air circulation, again, increasing the risk of an ear infection that way too. Okay, so again, certain things such as Debrox, hydrogen peroxide is very commonly used. Some people use oils like mineral or sweet oil, also commonly called almond oil. Those kind of provide some moisture and help things to loosen up a little bit. I generally don't recommend that unless we really have a patient who has really hard cerumen. And if their eardrum is intact and they don't have any skin problems, I do allow them to go and use that prior to coming in to soften up the wax so it's easier, more gentle on their ear before I see them. Between these products, there's really no major difference. So whatever that they can find and if it's safe for them to use, it's okay to use. Let's see. Again, be careful with somebody who's had a history of dermatological or tympanic membrane perforations. Irrigating, there's a variety of different tools and instruments, kind of depends on which clinic setting has purchased whatever product they have. The ones that are actually more syringe-based with a bulb and a syringe, I've had a number of patients that I've seen sustain traumas from them. And I kind of discourage the use of those products. But again, there's any risk with any tool or instrument that you use. There's always a risk for perforation or trauma to the ear. So you just have to be very diligent with your experience and expertise and what you feel comfortable with. And again, there's always a risk. Even from our clinic, we still have the potential for causing trauma to a patient too. If you use water, you want to use warm to tepid water as close to natural body temperature as possible. You don't want to use cold because the cold will stimulate vertigo of the inner ear. And obviously you don't want hot because of the risk of burning. Let's see. Irrigating with water or saline. Some people prefer saline. There's really no benefit to using saline. As long as it's safe for them to use water, they can use that too. And again, be careful with the irrigation in those populations that I discussed earlier. Removal, we have a very high variety of instruments that we use in our clinic that is strictly designed to be used with binocular microscopes that we have in our ENT clinic. I do not advocate using those in a primary setting because you don't have the proper visualization. Let's see. Okay, so a lot of these we already talked about. And again, just kind of educating patients, try to minimize self-cleaning and using tools and instruments because that does cause recurrent trauma and increased risk of infections as well. Okay. All right, so next item, the foreign body in the ear. This is a subject where I don't see, let's just put it this way, you'll see more foreign bodies in the pediatric population than you do in the adult population. However, we still do see a fair number, and most of those foreign bodies would include things like Q-tip cotton swabs that are fallen into the ear that's trapped that they can't get out because they were abusing the Q-tips in the ear. Hearing aid silicone molds. In some hearing aids, they actually have a little earpiece that's made of silicone, so it's really flexible, that easily plugs in, gets stuck, and when they take the hearing aid out, that stays in the ear, so they can't get it out themselves. Other times, we'll have people with bugs in the ear and unwanted things that doesn't belong in there. And so, as you can imagine, I've found some very interesting things in people's ears, but they need help to get it out. So if it's a foreign body, just send them to ENT. If it's something that you feel very comfortable, you can try flushing it, but if it gets lodged even further and they're having more pain, obviously stop and send them to an ENT doctor. In our clinic, if we find any concerns for, let's say it's a battery, a small hearing aid battery, again, you'll see this in children more than adults. I've never seen a battery in an adult ear. But if there's anything corrosive, such as a battery, or even food, if food has ended up in the canal, there's a chance that could actually blow up or inflate and cause corrosion and infection to the ear. Those are considered to be medically urgent. They need to be removed immediately by ENT. Other things, if it's a bug, and if it's still alive, you want to drown and kill the bug first by pouring mineral oil in the ear for a good 10-15 minutes. And then attempt to remove the bug. I have had to do that a couple of times and has been pretty successful. Okay. All right. So foreign body management, we just kind of talked about some of those things of being careful. You don't want to cause any trauma to the ear. So again, if you feel that you need to send the patient to an ENT, please do so. Use of antibiotic drops may not be necessary unless the canal is inflamed or there has been any trauma to the ear as a result of the object itself or during the attempted cleaning. And if you do feel you need to give the patient an antibiotic, Flaxin or Ciprodex are appropriate for that. Avoid the use of acetic acid in a very irritated or abraded ear canal because it can be very acidic and cause a burning sensation. Okay? And never use acetic acid if the patient has a TM perforation. Okay, otitis externa, we talked a lot about that during our assessment class and what it looks like. Most common organisms are Pseudomonas, as well as Staphylococci, as well as a variety of other organisms. Fungal otitis externa is a little bit more challenging to treat. It takes a longer period of time. It's a little bit more persistent. So you can kind of tell based on the illustrations and photos I showed before in the assessment class that there's little black or white furry kind of powdery substances sitting on the ear canal and the wax or dead skin. So you just want to keep a lookout for that and treat that appropriately if you feel comfortable doing that. Common causes for otitis externa, obviously moisture, humidity, water contamination, plugging of the ear due to foreign objects or other things in the ear that's preventing proper ventilation. Dermatologic conditions that the patients may have, such as eczema or psoriasis, exacerbate the risk for otitis externa. Anatomically, if they're narrower in the canal, they're very commonly known to have frequent ear infections as well as recurrent trauma to the ear from use of other objects in the ear. Okay, so pertinent things that you want to know about the diagnosis of the otitis externa. Usually the symptoms are quite rapid. They can happen within a matter of hours and days. Typically it's acute pain, inflammation, some itching. The ear feels full or plugged. They may or may not have any perceived hearing loss, and they may or may not have any jaw pain. A lot of it is, in terms of physical exam, it will be swollen, it's puffy, it's red. You might see fluid draining out. The ear canal and the opening could be so swollen and so inflamed that you can't even see down to the ear canal. That is pretty severe. And typically with those patients, what we're going to talk about now is how do you manage that? Okay, so obviously the identifications of what to look for. If you're going to treat it, you can start using some drops if the drop can go through the canal. But if the canal is so swollen that you can't get any drop in there, that means you need to send them to an ENT to have a tiny little sponge called an otowick inserted into the canal. That will allow the ear drop to absorb into the sponge and down the canal to have a benefit in treating the otitis externa. All right, so differentials for other otitis externa could be a viral form of infection, such as herpes zoster or Ramsay-Hunt. And sometimes if it's quite severe, you may not even know if it's really an otitis externa. It could be a different extraneous type of medical condition, such as a parotid mass or parotid cancer or skin cancer. You just have to be very diligent and keep that in the back of your mind as part of your differentials. Okay. So in a patient that if you have an ear infection, you're trying topical drops, if it's not working and they're not responding to the medication, then the ear culture may be appropriate. If somebody is immune compromised and there's a greater risk for serious infection as a result, it would be appropriate to go ahead and do an ear culture on those patients as well to isolate what exactly they have to really properly and immediately get them on the right drug. For some patients who have serious conditions that's spreading with the infection invading to surrounding tissue, a CT of the bone without contrast would be appropriate in such cases as a malignant otitis externa, mastoiditis, cholesteatoma, carcinoma, or facial or head trauma. All right, in treatment, I sort of covered this already, but typically ototopical antibiotic ear drops are the standard treatments. However, oral antibiotics with topical drops will be only appropriate in the following situations: if the infection is extending beyond the ear to surrounding tissues, and it's becoming more, having more symptoms of lymphadenopathy, swelling, pain, tenderness around the lymph nodes to the surrounding area. And especially if they are already immune suppressed. Those are the individuals you have to be a little bit more diligent with, or if they have chronic diabetes. Again, they can quickly change and become much, much worse. Anybody who has a history of ear tubes or perforation in the ear, the only two topical drops, again, that you can use is Floxin or Ciprodex. Those are the only two FDA approved. Anything else other than that have not been FDA approved. There is a risk for potential ototoxicity. Okay. Somebody who's had a history of ear surgery, such as a mastoidectomy, they can often have recurrent cholesteatoma, which is why they must continue to follow up with ENT for a lifetime basis. And so if there's any concern about infection in these individuals, please just refer them back to their ENT. All right, so this is a algorithm that helps you kind of in determining what to do with these patients. So with this, it just kind of goes through the basis of patient presents. And if they have already been treated, but they're not responding, what do you do? And then you kind of talk about different ways to manage it. Do they have a perforation? Do they not have a perforation? And so hopefully with the extra handout that's all blown up for you, you'll be able to better read these algorithms to give you better guidance in the direction how to manage these patients. So I don't expect you to be able to read this from the screen. So those handouts that you get separately is meant to be printed up so you can read them. Okay. All right. Benefits of topical therapy, obviously they're highly effective because they're super concentrated, and they provide the most benefit and as quickly as possible as well. Actually, some patients do notice improvement in 3 to 4 days, or they should be. If they don't, obviously they need to be reevaluated to see what else is going on. The use of oral antibiotics is discouraged unless, as we talked about earlier, they have advanced disease and things are spreading out. Typical organisms that are most commonly associated with the infections, again, is Staph aureus or Pseudomonas, and for that you want to use an antibiotic that is isolated to treating those particular organisms. Okay. Now, typically, there's no difference in outcome between the use of a quinolone, such as Cipro or Levaquin, versus a non-quinolone. So monotherapy versus combination, there really hasn't been much of a difference. So just focus on using those FDA-approved ear drops that we are discussing today with the Floxin or Ciprodex. Okay. The risk of using the topical drops, some people can develop a allergic reaction, get contact dermatitis, otalgia, dizziness. Some people do feel vertigo. Oftentimes when people use drops, if it's cold and they put the drop in there, they can get a little vertigo sensation. So have them warm it up in their hand under warm water in the bottle and then put the drops in if that's really the vertigo is because of the coldness. The concern with use of topical drops, also with any use of antibiotics, is the potential for resistance and superinfection. Okay. Fungal infections, again, does not require or an antibiotic is not indicated for fungal treatment. Typically, they have a variety of different ways of managing that, and I'll discuss that in a moment. Contact dermatitis is commonly seen in people with sensitivities to neomycin, and that's commonly found in cordyceps drops. Now, cordyceps is a drop that contains 3 to 4 different ingredients. Neomycin is the one agent that a lot of people do have sensitivities to, and they develop contact dermatitis. And so if they've ever had any history of that, please do not use that. Also, do not use cordyceps in somebody who has perforation, because neomycin can be ototoxic to the inner ear. Okay. The concern with using any medication, including drops, is non-compliance. People use it for maybe 2 or 3 days, think they're getting better, and they stop. You must counsel them to continue the course of the treatment for the full 7 or 10 days that you are prescribing that. Okay. So this is a list of common ear drops that are available in the market. Acetic acid is a very standard vinegar that's been sterilized and safe to use in the ear. Again, you do not want to use this in a perforation. But it is safe to use for a normal intact ear that requires some form of topical agent. Acetic acid is great for otomycosis as well. But other agents include the acetic acid with a steroid for somebody who has swelling and inflammation of the canal, ciprofloxacin HC. There's Ciprodex, which is the most commonly used for a lot of our patients now because it's such a wonderful drug. The only drawback, it is super expensive. So it could be up to $150 for a bottle if it's not covered by insurance. Okay, and ofloxacin. The problem with ofloxacin right now is there's a halt in manufacturing of this right now, and we are having a major problems obtaining this. So what we're doing recently is just switching over to ofloxacin ophthalmic drop that is safe to use in the ear. So right now that's the only option we have if we cannot use Ciprodex. So just be on the lookout for that. You might run into this. We don't know how long this issue with the manufacturer is going to be, but this includes generic as well as a trade brand, so we don't know what's going on. All right, oral antibiotics for otitis externa, as we talked. Systemic antibiotics are only warranted in these compromised patients with HIV, immune suppression, diabetes, significant spread of disease to the surrounding tissues. All righty. Orally, if you do feel that you need to prescribe them something, the 3 options are ciprofloxacin orally, any version of the cephalosporins that are available, as well as erythromycin for penicillin allergy patients. Additional recommendations before I move on to the next subject. An ENT referral urgently for wig placement is important. If the patient has signs and symptoms of spread of disease, if the patient is not improving and they're persistently having problems despite different options that you've been trying in the patient. And also, if they have a history of a perforation, you need help with managing the patient better, please feel free to refer them to an ENT. Okay, so this is kind of more of a patient handout information. Again, you have a handout that's blown up so you can see a little bit better. So these are a lot of very common question and answer format, which is very helpful not only for you, but also when the patients are being managed, you can review this as a way to educate yourself, and then you can counsel the patients later too. Very, very, very helpful information here. Pain control. Anybody who has an otitis externa will never ever forget the severity of the pain. This is quite intense. It can literally knock a patient out for an entire day or two until the pain gets better because it is such a severe, intense pain. If over-the-counter analgesics such as Tylenol or ibuprofen are not helping you, please tell them. I will be more than happy to give you a narcotic for this because it is a very painful infection, and it is warranted to provide them a few days of narcotic for this. Let's see. Oh, topical analgesics like benzocaine or Oralgan is the trade name. We generally do not recommend or use this product. The problem is if you use it, and they feel free to use it whenever they have any ear pain, they could be masking a severe ear infection. We generally do not recommend this drug, and ENT pretty much banned this medication. There is some recent reports that a lot of medical organizations are, I don't want to use the word ban, but they're discouraging the use of the benzocaine as well. So we'd highly recommend that you try not to use them at all. Okay. Malignant otitis externa, also called necrotizing otitis externa, is a very aggressive form of Pseudomonas aeruginosa, as well as MRSA is an increasing population of patients with that infection that is spreading in the community. We do often see that in the ENT area as well. Contributing factors are potentially other underlying comorbidities, as well as trauma, irritation, frequent infection, and contact with other sources around them. These patients have much more severe level of intensity of pain and discomfort. Some people may experience facial paralysis or weakness. So again, you just have to be careful and look out for these patients. And a common finding also, you may see a small mass, granulation, or polyp in the ear canal that is not getting better, and it may be suspicious for a lesion, but also if you have other symptoms that correlate with a malignant otitis externa, please send them urgently to an ENT for immediate evaluation and management. In some cases, if you feel that you've been doing the topical and you've been doing the oral and you're not getting better, one consideration is to send them directly to the ER if they're severely compromised and they look very, very ill. That way they can get an immediate CT scan to figure out if this is how bad the spread of this malignant otitis externa really is. And typically, if they're that acutely severe, they are often admitted for pain control and IV antibiotic infusion as soon as possible. Okay, otomycosis, fungal otitis externa, very common as well. Humid, warm, southern states, as well as even here, typically in the summertime. Aspergillus and Candida are the most common organisms, and typically it's a thick, pasty, kind of yellowy, kind of gunky looking debris that just kind of looks really kind of pasty, I guess is the best word. If they're so impacted that you can't get any drop in them and you want to start them on therapy right now, as long as they don't have any history of perforation or surgery, it is okay to flush the ear first to get all the gunk out and then start them on a topical ear drop. So acetic acid is the choice of drug that we prefer. It does take time, several weeks perhaps, to get that treated. If not responding at all, then please refer them to an ENT for other advanced management. Oral antibiotics are not indicated for somebody who has otitis from otomycosis. However, some people can have both fungal as well as bacterial infections at the same time, and only the use of a culture will be able to isolate that so we can treat them properly. Okay. Non-infectious chronic otitis externa, common conditions such as eczema, seborrheic dermatitis, also very commonly seen. I manage a lot of these patients. The best way to manage this excessive fluctuation of the inflammation, the irritation, the sloughing dead skin is to control that with the use of a very low dose topical steroid such as hydrocortisone. There are prescriptions such as triamcinolone that we often prescribe. It's a low dose. It's very safe to use in the ear. Our typical recommendations, and also a drop called Dermatic, which is actually fluocinolone in an oil suspension. That can be also very helpful. So we typically suggest that we use them twice a day for a couple of weeks until the symptoms settle down, and then they kind of use a little bit less, such as 2 or 3 times a week to maintain the medication without having to use it every day anymore. Okay. Counseling for acute otitis externa, avoid trauma, scratching, using foreign bodies. keep the water out. They can use a cotton ball, coat it with petroleum gel all around it, and plug the ear before they shower or bathe, and then remove it and wipe it off. Other things, swimmers, if they swim often and they have frequent ear infections, they can use swimmers' earplugs as well. Sometimes taking a blow dryer and just kind of blow drying it about an arm's length away, kind of pull your ear up and back and use a blow dryer, just kind of do that for about a minute or two, helps get some circulation to the ear after they washed up. Some people use, or people who are really health oriented have heard that tea tree oil may be of benefit in preventing infection. We discourage that as there is no clinical proof that that is helpful, not to mention the potential risk of causing corrosion or damage to the ear. Eustachian tube dysfunction is an abnormality of the eustachian tube between the middle ear and the posterior nasopharynx. Oftentimes creates this plugging, fullness, heavy pressure in the ear, and it is worse when they're descending on a flight. Associated factors include chronic congestion, upper respiratory infections, allergies, tobacco use, as well as reflux disease. Other things such as cleft lip palate, which is a congenital problem, can also be associated with eustachian tube dysfunction. Signs, the eardrum may be retracted. Patients may not be able to ventilate it when you ask them to pop their ears. They may look congested from allergies or a recent upper respiratory infection. And if you have a pneumatoscope in your clinic and you're able to perform that, you'll probably get a flat reading, and because the eardrum is not moving very well. Management of the eustachian tube dysfunction is to try to pop their ears open. A lot of people really don't know how to do this. So what they have to do is inhale, get the air up into their lungs, plug their nose with their finger, and try to close the glottic, the palate with their tongue, so that they are not able to breathe through their mouth, and try to inhale up into the ears so that the eardrum is popped open. Some people really can't do it, even if they do it correctly. That's because of the eustachian tube dysfunction. So you try to encourage them to do that. Other things that they can do is try to chew gum, try to yawn, try to sip water, things like that, to see if that provides any relief. Use of oral decongestants is something that they can try. Of course, you have to be careful of the potential side effects from that. Topical, such as Afrin or neosynephrine, only limited use for only 2 or 3 days. We don't recommend any further than that because of the risk of rhinitis medicamentosa, which is kind of a addiction that they can have over a prolonged period of time from using that. Okay. Middle ear infections, otitis media, inflammation of the middle ear. So these definitions, you'll hear in different ways. I just put this out here as a way to make sure that you kind of have a really good, thorough knowledge base of what this means. Otitis media is essentially just means inflammation of the middle ear. Otitis media effusion is actual fluid from the inflammation that is obstructing the middle ear space due to the fluid, because it's trapped and it can't drain out through the eustachian tube. Suppurative otitis media means that the patient has drainage, active drainage, whether it's through a tube or perforation, or if they have chronic drainage as a result of a cholesteatoma and granulation that's formed in the ear, and that's draining out. Mastoiditis is an inflammation of the bony space around and behind the ear, and that can cause some that can be commonly seen in somebody who has frequent ear infections as well. Labyrinthitis is an inflammation of the inner ear structure, causing hearing loss and vertigo associated with the inflammation to the ear. Acute otitis media, typically acute means the symptoms have been for less than 3 weeks. Chronic is if the symptoms have been for more than 3 months, but subacute is between the 3 weeks and the 3 months. So you can have a patient falling in any of those categories, but you can define acute, subacute, or chronic based on the duration of those symptoms. So common associated factors include allergic rhinitis, non-allergic rhinitis, chronic sinus disease. A lot of patients who have had radiation to the head and neck or nasopharyngeal area, they are most commonly associated with having effusions of the middle ear. And so a lot of those patients do end up with ear tubes in the ear. Also, just bear in mind, if somebody has a unilateral or chronic bilateral otitis media with effusion that is not relieved by different medications, they should be scoped by an ENT to look for the possibility of a nasopharyngeal carcinoma. Okay. All right. Organisms commonly associated with acute otitis media. Most common is viral, as we all know. Fungal in a small percentage of people. Bacterial organisms, which are very commonly associated with strep, Haemophilus, and Moraxella. MRSA is also, again, increasing in numbers in the community as well, so be aware of that. Chronic acute otitis media is more associated with Pseudomonas, Proteus, E. coli in some cases. So again, we just don't know how some people may be getting E. coli, but it's out there, it's happening, and we've isolated them in cultures as well. Biofilms is a new concept that's been around for maybe 10 years now, that is increasingly becoming more accepted in the ENT community. Biofilms are aggregates or sort of surface elements that are developed by the bacteria to protect itself from antibiotic use. And so it's difficult to treat the infection because the bacteria has found a way to protect itself by creating a filmy residue that doesn't wash off, it doesn't get treated by antibiotics, and it's creating a very interesting layer of debris that's just really hard to penetrate and kill and get rid of. And so there's increasing studies that they're doing to try to learn how to eradicate and get rid of the biofilms. But it's a growing concept. They're still studying the actual nuances of why that developed and why bacteria have developed these biofilms. Anybody who has a spontaneous eardrum rupture, again, sometimes it can be due to acute otitis media with excessive pressure from the pus that finally just relieves itself by perforating right through the eardrum. Trauma is very common. Sometimes when people are diving or they're flying due to the excessive pressure, they can develop a spontaneous rupture as a result. And so this can cause an acute sudden change in hearing and obviously pain, as well as possible bleeding or drainage of the effusion from the middle ear. Typically, treatment would include, if it looks infectious, certainly put them on topical agent if the hole is still there. However, if it is healed up but they're still having symptoms, an oral antibiotic would be appropriate. And I'll show you some more information about that. Patients typically are fearful that they're going to have recurrent problems with this. You just have to reassure them that in most cases, a perforation usually does heal spontaneously. It could be a matter of a few days or a matter of a few weeks. You just need to make sure you follow up with them to make sure it's healed up properly. If it is not healing, that's when you want to refer them to an ENT. And typically the time frame I give a patient would be, let's give it a month and then see if it's getting smaller. If it keeps getting smaller over time, you just keep watching them. But if it stays the same size and there's no improvement, then at that point, depending on how frequent infection they're getting or if they're having symptomatic problems with hearing loss, that's when you would refer them to an ENT. Okay. So complications of an acute otitis media, this is more on the extreme side, and unfortunately, these cases can happen. It's not as often in the primary setting, but I just want you to be aware of that. The acute otitis media can lead to serious problems such as mastoiditis, granulation, labyrinthitis, facial weakness and paralysis, thrombosis in extreme cases, an abscess, subdural abscesses, meningitis, and hydrocephalus. And again, those are more on the extreme on the lower side, but it can happen. It's been documented. Immediate workup is necessary, referral immediately to an ENT. If, however, the patient is exhibiting neurological signs, please refer them immediately to the emergency room. Okay, treatment for acute otitis media. Generally, no evidence to support that withholding antibiotics treatments from an adult with an acute otitis media. So if you're withholding a medication, there's no support for or against it. In some cases, if it was viral, it's going to resolve on its own. If it's bacterial, symptoms may persist, or if the body's immune system naturally kicks it out, it may take some time, but the body may eventually be able to eradicate the bacteria. But unfortunately, in some cases, people end up continuing to be miserable. It's impacting their quality of life. They do need treatment. So antibiotic treatment is appropriate in that situation. First line of treatment generally is plain amoxicillin. And the dosing is based on how mild the symptoms are or how severe the symptoms are. And then the second line, if the plain amoxicillin has been tried and has failed, or they have a history of recurrent problems in the past, second line treatment would be augmentin, also called amoxicillin clavulanate. And then again, based on how mild or how severe, the number of days that you're prescribing it would be appropriate. I generally prescribe 10 days because those are the patients that I see with more severe types of sinus problems, more recurrent problems. I usually go for a full 10 days. Somebody who's really severe, the option also is Augmentin XR, which is an extended release at a much higher dose of 1,000 milligrams per 62.5 milligrams of the amoxicillin carbalinate combination. Give them twice a day for 10 days. Just caution them when they're taking this. There is a high chance of either diarrhea, loose stools, or especially for women, vaginal yeast infection. So encourage them to use probiotics and do everything they can to eat yogurt and things like that to kind of help minimize that. And always keep a lookout for any potential signs of C. diff. All right, so the alternate options are cephalosporins, azithromycin, as well as Bactrim DS. And I highlighted DS to make sure you give them the full DS double strength dose of the 160 per 800 and not the lower strength. Okay, analgesics if they need for like Tylenol or ibuprofen for the bad earaches, that's perfectly appropriate. All right, and then alternatives to penicillin allergy patients are including such as, actually before I go into that, so somebody who has, they say they have an allergy to penicillin, you want to be more inquisitive about what they mean. They may have been so young that they don't know exactly what happened other than they were told by their mom that they shouldn't take penicillin. So you have to kind of decide whether or not to test them out with any of these cephalosporins, because if they have not reported any rash or hives with penicillin, you are most likely safe to go ahead and give them a cephalosporin. It's the ones that have the rash or the hives who have confirmed rash or hives after using a penicillin derivative. You don't want to give any of the cephalosporins because there is a small chance that they can react to that too. All right, so erythromycin is an alternative option. Sulfoxamide, azithromycin, clarithromycin are other options as well. Bactrim is also an option, but may not be the best one based on certain regions of the U.S. Okay. Middle ear effusions are just fluid in the middle ear due to inflammation. This is not an infection. There's no signs of redness. There's no signs of pus. There's no bulging of the eardrum. There's no acute pain with it. It's just fluid. Kind of has a golden to light color to it. These may persist for weeks or they may resolve on their own. Typically, if they persist for more than 3 months without any improvement, they would be referred to ENT. Let's say they have frequent ear infections. You also want to refer them as well to ENT for frequent ear infections, frequent recurrent otitis media with effusion. If it's unilateral, again, you want to rule out any risk of nasopharyngeal carcinoma, so you should refer them to an ENT to have that examined. Okay, treatment. All right, so the ear popping or autoinflation or Valsalva maneuver to try to pop the ears if they can't do it, but it's worth trying as often as they can. The use of topical eardrops has no benefit in somebody with middle ear infusion. There's no reason why you should be giving anybody an eardrop for that. The use of oral or topical decongestants would be appropriate to try. If somebody has allergies, definitely have them take some antihistamines for that to see if that would be helpful. Nasal steroid sprays are appropriate to use to see if that'll help with reducing any nasal congestion and inflammation. But if they have no allergies, if they have no nasal congestion, no nasal symptoms, there's really no benefit to using the nasal steroids other than try the topical decongestants or oral decongestants. Okay. And let's see, ear tubes indications. All right, so there's different types of ear tubes for different reasons. And there's the short-term ones and then there's the long-term ones. The ENT decides which ones they're going to do. But you'll see a variety of different colors and shapes if you ever look into a patient's ear with an ear tube. So criteria for placing ear tubes are, again, recurrent acute otitis media, that's affecting their hearing and communication. If they're having recurrent issues with balance issues because of the fluid and frequent infections. Somebody who has Down syndrome, cleft palate, or history of recurrent bowel trauma, there could be good indication to go ahead and put tubes in those patients. Some people, they have to be educated that there are risks with having ear tubes, such as chronic perforation after the tube has fallen out, risk of granulation, inflammation, infection, risk of cholesteatoma formation because the eardrum isn't healing properly. They could have scarring, but that's kind of minimal. Any risk of hearing loss as a result of they cause a perforation, sometimes after the tube has fallen out, the perforation can get bigger, and if it gets big enough, it will impair their ability to hear. So those are potential risks of using ear tubes. So this is not a quick fix. It is not perfect. There's always risk with anything, including ear tubes. When you're managing, let's say you have a patient that you're seeing who has tubes, but they're really not having any issues, some things that you want to be aware of, that just counsel them that if you have an infection, you have drainage, that's expected, especially if you have an ear tube, because it's allowing the fluid to drain out. So it's nothing to be alarmed about. And if they have an active infection, it's okay to go ahead and give them some ear drops to treat the infection. Encourage patients to avoid the use of water. Try to limit the exposure to lake water or open water because of the contamination and increased risk of ear infections. The only thing is, there are some ENTs who believe it is perfectly safe to be exposed to water, like swimming pools, chlorinated water, that type of exposure. They feel that the tubes are so small that there's minimal chance that the water is actually going to go in. Whereas other providers have a different opinion because they've had patients who have had some water exposure who still got infections. So it's a very kind of controversial thought process in terms of what clinicians prefer versus not. So you have to kind of use your judgment. I usually tend to lean towards avoiding the water. So that's kind of where I'm at with that. But anyway, one other thing is detergents like soap, shampoo, they actually encourage water to be, because you know how when you take a shower in your bath and you put a little drop of water on your skin, the water just kind of balls up because our skin has a protective layer to it. But if you use soap and you wash that, the water just clings to your skin. So the same thing's going to happen to the ear if you've got soap and shampoo in your ear. And if the water is going to cling and just encourage the water to sit there and potentially encourage water to go into the ear as well. So just kind of be careful to avoid detergents and counsel patients accordingly. Treatment of patients with tubes who have ear infections. The best treatment is topical antibiotic drops, Floxin, Ciprodex. Do not use Cipro-HC. Cipro-HC has not been approved by the FDA for use in people with perforations. The only two agents, like I said, ofloxacin called Floxin or Ciprodex, are the only two FDA approved for use in people with perforations or ear tubes. And right now we can't even get ofloxacin, and Ciprodex way too expensive. So you see the dilemma we're having because it's getting increasingly difficult to treat patients right now. All right, so floxacin, ofloxacin, and then cortisporin. I mentioned earlier, the cortisporin is a combination drug. As long as they have a normal eardrum and they have no problems with neomycin, you can use that for, let's say, otitis externa, but never use cortisporin in somebody with a hole in the eardrum or an ear tube. So the cortisporin is contraindicated in these patients. All right, so when people fly and they have eustachian tube problems, again, the ear popping is one option. Using the decongestant is an option. There's something called earplane earplugs sold over the counter in the earplug section. It actually absorbs the pressure of the pressure change in the cabin during the flight so that their ear does not suffer the pressure changes and pain. And some patients have had very good success with this. It does not work, however, if they have had previous ear surgeries where their ear canal has been widened and it may not fit. I would not recommend this in somebody who has an abnormal ear configuration, such as a narrow ear canal or exostosis, or somebody who's had chronic dermatitis or skin conditions. They may have increased problems with the skin if they wear this for several hours. So next thing is hearing loss. I've mentioned this before during the assessment class that anybody who presents with sudden change in hearing is a medical emergency. And I'm going to talk more about that in the next few slides. But in general, it is critical to identify what type of hearing loss they have, whether it's conductive or sensorineural, and to determine, as quickly as possible, the severity of the hearing, meaning they should get first of all, if they have a sudden hearing change, physically see them, number one, is it wax or is it an infection filled with fluid and pus? That you can manage on your own as a primary care provider. But if there's no sign of infection, there's no sign of a wax, and they're complaining of hearing loss, you need to refer them immediately for an audiogram and to have that audiogram done as soon as possible, within a day or two. Ideally, less than a week, but the sooner you can get them in, the sooner we can get them treated if it truly is a sensory neural hearing loss. Okay. All right. So conductive hearing is different from bone conductive. All right, let's break this down. Air conduction versus bone conduction hearing. The way we hear is through sound waves traveling through the ear canal, hitting the eardrum, vibrating through the 3 little hearing bones, going to the cochlea, transmitting the sound through the cochlea to the auditory nerve, and then to the brainstem, and then back to our brain. And that gives us the interpretation of what we're hearing. Now, let's say something physically is blocking it, whether it's an earplug, an earwax, or fluid, and that's not allowing the sound waves to travel through, that would be conductive hearing loss. We still, when we test patients, we are able to bypass that conductive hearing component and actually test them through what's called bone conduction by putting a small little headset that's attached to the bed, a headset that we are actually sending signals and sound waves through the bone directly to the cochlea. So we don't have to worry about this pathway. The way we truly test if they truly have sensory neural hearing loss is by doing this bone conductive study. That we can guarantee will be very accurate to tell us if they have true hearing loss or if it's just a conductive type of loss. All right, so conductive loss is a physical blockage. Could be due to enlarged perforated eardrum, an unusual formation of ossicle. They've had a trauma, the ossicles are dislocated, or wax, fluid, those kind of things are physically obstructing the sound waves from transmitting. When we manage these patients, we find the source of the conductive loss and get that properly treated, whether it's wax removal, treatment of the ear infection, drainage of the fluid, or surgical correction to fix the ossicles. Some people can have what's called mixed hearing loss, meaning they have both conductive hearing loss and sensory neural hearing loss, and we'll see that in our hearing tests as well. A lot of those patients may require a little bit more advanced management, so in those patients and you don't know what to do, please feel free to refer them to ENT. Unless it's something obvious like wax or ear infection, you can manage that too. All right. Sensory neural hearing loss, again, is true nerve loss of the inner ear and the cochlea, or there's a disorder or damage to the auditory nerve itself, and the sound and the signals are not traveling through to the brain. So common causes include age-related hearing loss, which is called presbycusis. Bacterial or viral infections can penetrate and damage the inner ear fibers of the cochlea and cause hearing loss. Noise exposure, sudden acoustic trauma such as explosives, and fracture of the cochlea. Somebody's had a fall. They fall 15 feet from the building and they crack their head and they also fracture the cochlea. They are permanently deaf as a result of that. Cannot be repaired, cannot restore the hearing. If that cochlea has a fracture, that usually is complete deafness. Inner ear disorders such as Meniere's disease is also a common cause for sensory neural hearing loss. Congenital deafness, whether they were born with the deafness or they can develop later with age. I've seen a gamut of all kinds. Okay, let's see. Audiograms, we talked about a little bit earlier. Audiograms are considered the gold standard. They generally are performed in a sound booth by a licensed audiologist. This again assesses the type of hearing and the severity of the hearing. Screening in older adults. Screening is fairly important because as we do get older, we do slowly and gradually start to progressively have some hearing loss. The harder it is to hear, the more isolation that they have because they can't communicate, they can't understand what's going on. They start to isolate themselves. That is not very good with in terms of their mental status and socialization. It's important for them to be able to hear to continue to maintain socialization with family and friends. Okay. Now, if for screening purposes, should we automatically be screening everybody for hearing loss? No. Obviously, if they're subjectively complaining of hearing loss and it's bothering them, yes, definitely go through some screening process to have a hearing test. But if it's let's say somebody's older and you're thinking, oh, you're kind of in an upper range of your hearing, I kind of wonder if you have some hearing loss. should I send you for a hearing test? We generally do not recommend screening everyone for hearing loss unless they are symptomatic and you have concerns that they're not hearing well. So it's kind of driven based on patient symptoms. All right, sudden hearing loss. Now, again, this is emergent and requires immediate referral. An average of 5 to 2 people out of 100,000 population usually will have sudden sensorineural hearing loss. And there's typically an average of 4,000 new cases every year in the U.S. So it seems small compared to some other conditions you can have, but we see a fair number of them even in our own clinic. So every day we have a high alert coming in that there's a potential sudden hearing loss patient. So we might have to see them at the last minute. Typical presentation, there's a sudden rapid change in hearing. It can occur in a matter of hours or in a matter of days. Plugging, fullness, pressure, different people describe it differently, but they just don't hear as well. They feel like there's like a cotton ball in there. They just want to pull it out and just make it hear better, but they can't. There's nothing there. They may or may not have ringing or tinnitus with this. They may or may not have any vertigo with this. But pain is not associated. The only time pain is associated is, let's say, if there's infection or some concern for referred otalgia, such as a mass in the throat or something like that. Most common causes for sudden sensorineural hearing loss attributed to vascular, viral, or other chronic comorbidities. Idiopathic sudden hearing loss is considered an unknown, uncertain cause of hearing loss. You can't figure out anything else no matter what you're trying to do with your history and your screening. So idiopathic is anything that doesn't fall in the category of any of these known factors. So the prognosis kind of depends on how quickly they're seen, how quickly they're started on treatment, and whether or not their overall condition, whatever it may have caused it, can be reversed. Okay, what I mean by that is we can see them sooner. We can certainly get them started on some steroid, and I'll show you what we typically do. But this slide shows different causes for bilateral sudden hearing loss, and there's a whole host of those issues. This is very rare. We don't normally see this, but I want you to be aware of this. So this is why I'm giving you this slide handout in that packet, to be aware of some immediate concerns of bilateral sudden hearing loss. Some of these are medically urgent that require evaluation. So when you diagnose sudden hearing loss, obviously you'll need an audiogram, and we look for certain parameters that would define sudden hearing loss, and that's listed here. There's no laboratory work required for idiopathic sensorineural hearing loss, because you've tried to figure out everything else to see what else is going on. Gold standard for imaging for somebody with unilateral sudden sensorineural hearing loss or bilateral sudden sensorineural hearing loss, MRI of the internal auditory canal with and without gadolinium is a standard, and that's what we order the most. Make sure if you are choosing to order this, make sure that they do not have renal disease, and you should ideally, actually should be required to do a creatinine test to make sure their kidneys are able to flush the gadolinium. There is a risk for what's called nephrotic systemic fibrosis in individuals who are given gadolinium contrast. Their kidneys are not able to flush and eliminate this and can remain in the body and cause damage. Okay, so when we treat idiopathic sudden sensorineural hearing loss, we generally provide them with high-dose oral steroids, typically 60 milligrams once a day for 2 weeks, some cases 3 weeks, followed by a slow gradual taper over the next 2 to 3 weeks. There are pros and cons to this. We do educate and counsel patients at length about the benefits as well as the risks of going on the steroid. And so I just kind of threw this in here that some providers in primary care are very comfortable prescribing steroids if they have had an audiogram completely, available, accessible to them. Patients have had it immediately and they feel it will be difficult for them to get into see an ENT. I feel comfortable prescribing it, so I have the parameters here for you on how to treat that. So in this middle column talks about the oral steroid dosing. On the right-hand side, this is not necessarily applicable to you, but one option is intratympanic corticosteroid injection done by an ENT. These doctors are neuro-otologists with highly specialized training in ear disorders. They can actually inject a steroid directly into the ear to see if that would provide some benefit. There's pros and cons to this. Not all patients would qualify for this. Only downfall is that we have not shown very good benefit or efficacy of this. The preferred option is oral steroids. Gentamicin, the steroid injection would be an option if the patient cannot take oral steroids due to underlying health problems, due to complications or whatnot. Okay, management. So obviously, additional things that we can do that we're not yet jumping on the bandwagon is hyperbaric oxygen therapy. It's something new that's kind of out there. We haven't had enough studies yet, but it's an option perhaps in the future. If there's enough evidence to support that it's beneficial, it's a possibility. But as of right now, we do not offer that, but it's something that's out there right now. The antivirals are of no benefit in these patients because they have not proven to be beneficial. Vasodilators, thrombolytics, other antioxidants, again, have had no benefit in reversing sudden sensory neural hearing loss in these idiopathic patients. Okay. Follow-up is very important, so they do want a repeated hearing tests over a screening process to see how their hearing is recovering or not. Okay, and educational handout, it would be the next one that I printed up for you, so you can have that available for you, not only for your education, but as well as for the patients. Amplification is definitely recommended and advised in patients with hearing loss, whether it's unilateral or bilateral, especially if it's impacting their quality of life, communication, and ability to function and manage their day-to-day activities. Cost is the only problem. Medicare does not cover at all, and some commercial insurances do cover a small segment or portion of the cost of hearing aids. So for those patients, it's a benefit, whereas everybody else is left in the dark. And they can cost thousands of dollars. So it's not a small thing. It's a huge cost-benefit ratio for the patients. And most patients try to put it off until it's really, really impossible to live without any hearing amplification. So alternative options that our ENT surgeons provide is what's called a bone-anchored hearing device. It's actually implanted onto the skull. And actually you attach an actual hearing processor directly on it. So it completely bypasses the ear and goes directly to the bone into the cochlea. This is great for certain people who have congenital deformities of the ear, and they don't have an ear, they don't have do you remember my talk about oral atresia? So those people really don't have this middle ear or outer ear anatomy, so they need some other ways, but their cochlea is still intact, so they use a bone anchor device to go directly through the sound transmission directly to the cochlea. There are other people who have had previous ear surgeries who can't hear with conductive hearing, or individuals who have had chronic infections from wearing hearing aids and they can't tolerate wearing it. Bone anchored hearing devices are a great option for them. Cochlear implantation are for people who have profound hearing loss. Typically, in the past, they were only approved for severe to profound deafness or sensory neural hearing loss bilaterally. Some insurances now will cover if it's unilateral. So it kind of depends. Tinnitus is a most common medical condition that audiologists are seeing patients for. It affects more than 50 million people experiencing some form of tinnitus at some point in their life. And it can definitely have a prevalence of 10 to 15%. It is an internal perception of sound described in different variations such as ringing, roaring, buzzing, clicking, pulsating. It can be unilateral or bilateral. It can be constant or intermittent. Okay. So this is just an overall, this is an action statement regarding tinnitus, of what you want to be doing to screen the patient for, the typical history that you want to be asking about, if they've ever had any imaging studies for the tinnitus, and how bothersome it really is. And some people are so affected by this, it affects their day-to-day activity. They cannot function, they cannot socialize, and so this is really important for them. And some people can actually be suicidal as a result of this because it's so severe. So this is very urgent in terms of getting this evaluated. This is that bad on these patients, so something to be aware of. Okay, now next section is common nasal sinus symptoms. We're going to jump right in there. All right, so common abbreviations. So,
Can we stop it? Just stop. Push stop. Why was it on pause?
Why?
No, if you